You have joined us for an overview of the key themes of the 2015 Corp statewide report. Before we get started, just a note about the technology. We do definitely want to hear from you, but so that we don't hear, cars whizzing by or dogs barking or phone calls or typing, we do have everyone on a global mute. So no need to wait till the end of the presentation to ask your questions. At any time during the presentation, if you have a question or a thought that comes up, feel free to type it in, and we will do all of those at the end of the presentation today. I am thrilled to introduce our panelists, my colleagues. First is Malia Christensen, who's the Executive Director at Corp. She has worked in almost all facets of healthcare, from clinical settings to hospital and healthcare system management. She joined Corp from the OHSU Center for Evidence-Based Policy, where she was the project director for the Medicaid Evidence-Based Decisions Project. Before joining the center, she was vice president at an employee benefit consulting company and served for 6 years as the administrator of the state Public Employees Benefits Board. She began her healthcare career in emergency services and critical care nursing. In addition to her role at Corp, she is the chair of the board of directors for the Network for Regional Healthcare Improvement, a national organization that represents over 30 regional health improvement collaboratives, which are organizations that do work just like Corp does across the country. Also with us is Douglas Rupp, or Doug Rupp, who is a senior healthcare analyst at Corp, working on total cost of care and payment reform projects. Before joining Corp in 2013, Doug worked for over 10 years in health insurance finance and product management positions. Other roles in manufacturing and publishing focused on process analysis and quality improvement. Doug is an industrial and systems engineering graduate of Ohio State, which I was happy to learn in the preparation for this webinar. I didn't know that about Doug. And in his free time, I did know this, Doug can be found with his dog, Costello. Last but not least is Cindy McElhaney, who joined Corp in 2011 as a senior healthcare analyst. She develops project plans, collects data, and publishes metrics and other reports related to healthcare quality and resource use, including providing consultation and validation for the Coordinated Care Organization performance metrics developed by the Oregon Health Authority. She has more than 20 years of experience analyzing administrative claims data in roles at a variety of health plans and works with other analysts here at Corp to ensure measurement and reporting is accurate and relevant to various stakeholder audiences like all of you on the phone today. Cindy has a bachelor's degree in math from OSU, and outside of work, enjoys walking and participates in Portland to Coast every year. So I'm happy to turn things over to Malia to tell you a little bit more about Corp and get us started.
Great. Thank you, Kate, and good morning, everyone. Again, delighted that you could all join us. I'm going to go through some initial slides just to give you a sense of our organization, what we do, who we are, a little bit about our background, and then set the stage for my colleagues to talk about the statewide report. So many of you might know us already. Some of you may be new to Corp. We have been around for 15 years. In fact, the first board of directors meeting was held 15 years ago last month, and we are excited to be celebrating 15 years. Our mission has evolved slightly over time, but the core mission remains the same. We're dedicated to improving the quality and affordability of health care for all Oregonians, so we are a statewide organization. And if you look at the next slide, one of the ways that we believe that we are unique is that we are rooted in the firm belief that in order to solve the large problems of health care, it's really important that all stakeholders have a part in the solutions. So while other organizations may do similar work within the boundaries or confines of their system or organization, we really think it's important to bring hospitals, health plans, consumers, providers, delivery systems, employers, and policymakers, as well as quality improvement professionals to the table together so that we make sure that we can focus on both the big picture and the on-the-ground picture at the same time. On the next slide, we are a member, as Kate mentioned, of a national network of collaboratives. So we call ourselves Regional Health Improvement Collaboratives, or RICs for short, because you needed another healthcare acronym in your set. And the real thing that distinguishes these organizations across the country is that although we may be structured differently, we believe in this multi-stakeholder approach. We also believe that data and independent and neutral data is critical. We believe that quality improvement needs to be coupled with the data to actually make changes, and we believe in the importance of payment reform as a critical component to changing the healthcare system. So the map shows the different members across the country. We are actually approaching 40. We have several applications in. And what this means is that almost 50% of the country's population is in a geographic area where they actually have a regional health improvement collaborative like QCOR to help. What does that mean to you on the phone and to other citizens? It means that we're working constantly with these other organizations to learn and spread best practices. And for example, this month there's a lot of excitement about payment reform that's coming from the federal government. We are dialed into this national network that's working on that together, so that we might be able to bring to Oregon some very unique technical assistance on that topic. Doug's going to talk to you about the Total Cost of Care project. That's another project that came to us through this network and also through foundation funding. On the next slide, what do we do at QCOR? So one of the things that is one of our hallmark core competencies is the production of neutral information. So we currently operate and we have created the most validated and utilized claims database in the state of Oregon. We're very proud of that. We have 100% of the Medicaid data for the state. We have 92% of Medicare claims data, and we have about 80% of the commercial, fully insured commercial market in Oregon in this database, which started in 2007. And so we're able to track individuals over time. What we've done with that data is to produce quality metrics originally. Then we moved into utilization measures, and we're thrilled to have introduced cost measures. And we can report at the provider level, the health plan level, and the general population level. Another shift that we've made in the last few years is the addition of pioneering analytics. So we're able to provide special reports to help others who are interested in improving the quality and affordability of healthcare. And we also do custom reports on things like payment models and quality improvement initiatives. On the next slide, we also lead and participate in a number of collaborations across the state. These are just 3 examples of those collaborations. We facilitate the Patient-Centered Primary Care Institute, which hopefully many of you are familiar with, that is in partnership with the Oregon Health Authority. We launched this year a brand new Oregon Maternal Data Center, which has been done in cooperation with the March of Dimes and a number of other larger organizations and the Oregon Statewide Perinatal Committee. We are thrilled about this new project because for the first time QCOR is actually receiving hospital discharge data and some clinical data sets, and we are rapidly approaching a mark where we'll have 50% of the births in the state in this new database, which is going to introduce over 40 new metrics on maternity. To the right of the slide, we also are very proud of our ongoing collaboration with health plans and other payers in Oregon. We have over 16 data suppliers in this report, including most of the major health plans, the state of Oregon for Medicaid, and also we were one of the first qualified entities in the country, which means we get CMS to give us Medicare fee-for-service data. On the next slide, what we're featuring and talking to you today about is the statewide report. This report is a snapshot in time, and we have about 2.7 million Oregonians that are included in the results of this report. We have over 3,300 primary care providers that we are reporting this information to, and we also have about 78% of the population of commercial Medicare and Medicaid included in this report, along with the data suppliers. And the thing I would underscore that makes QCOR unique is that this is a collaborative, it's a voluntary effort. All of the participants who provide us our data and help us with the measurement, selection, and the production volunteer these efforts with us. The next slide is just showing you where are we in a timeline of progression and health transformation in Oregon. The statewide report for 2015 looks at a solid year of claims data, and it was an exciting year because it's during this time frame that we saw a number of things happen. The ACA was in full expansion by adding the Medicaid expanded population. Cover Oregon and the Healthcare Insurance Exchange also entered the market at that time frame as well. And we have a lot of you know that the state of Oregon was reporting on the progress for CCL metrics, which includes Medicaid. But this is the first time at this level we believe that citizens of Oregon and the healthcare industry can actually see the information with Medicare, Medicaid, and the commercial population in one place. We know that there are a lot of significant changes that are related to the Medicaid efforts and the exchange efforts, but what we hear from providers over and over again is they get multiple reports consistently over time that are slices of data. This is an opportunity to really combine that data in a comprehensive way, and we think in looking at the information, and Cindy will share this, that it is very possible that the Medicaid changes and transformation are impacting results on the commercial and Medicaid side, or Medicare side, excuse me. And with that, we will drill down into some of the specific areas that are included in the statewide report, and I will turn it over to my colleague, Doug.
Thank you. As Maria mentioned, Corp has a long history of reporting on quality measures, both in reports like the statewide report and to clinics at the clinic level. In 2013, the Corp board decided that as part of achieving the triple aim for Oregon, Corp should begin using our extensive claims data to report on cost as well. And the cost information shown in this year's statewide report is our first effort in this direction. The response we've had so far has led us to, we really intend to continue reporting on cost well into the future. The healthcare costs are important to Oregonians. I don't think it's a surprise to anyone on this call, but they're increasing. They're a big part of what the state has to pay for and each of us has to pay for, and they really have to do with the overall competitiveness of our state. So just as an example of some of the things that would cost about the same as cost savings, we have in the report some things that if we could reduce healthcare costs by 2%, they'd be something that we could afford to do. And 2% equates to about $283 million a year. So just a small change in cost can really lead to big savings. As Maria mentioned, the cost effort that we have embarked on is working with other regional health improvement collaboratives around the country. And once Corp decided to report on cost, an opportunity came through the Robert Wood Johnson Foundation and for the Network for Regional Healthcare Improvement to work with 4 other regions around the country to develop the total cost of care measures for each region. So over the past 2 years, we've been working with Colorado, Missouri, Minnesota, and Maine on a specific methodology. It's the total cost of care methodology developed by Health Partners of Minnesota. And the measures are a population-based measure of cost of providing care to a group of commercially insured patients. And the costs are adjusted to account for illness burden, age, and gender so that we can standardize them. As I mentioned, the measures were developed by Health Partners, which is an integrated health system based in Minnesota. And they have made these measures available to anyone interested in using them free of charge. The measures are not perfect, but when we look around at other ways of measuring population costs, they really seem to be good or better than other measures that are out there. And these total cost of care measures were endorsed by the NQF in 2012. Health Partners and others have been using them for over 10 years. So Corp used our multi-stakeholder committee structure to develop reporting for primary care clinics. And the reports that Corp produced include quality and utilization as well as cost. And we shared the first round of reports on a pilot basis with clinics this spring. So a number of clinics have received the reports. They our part of the methodology is 600 or more commercially insured patients. So we did need that level of claims data in order to report on a specific clinic. And for the cost data in the reports, we broke the costs out by inpatient, outpatient, professional, and pharmacy, and then included drill downs on other areas, such as the ED and on imaging. And Shu from NODA asked about cost on disease condition. We also included a breakout of costs based on chronic conditions. So this is kind of our first look at that. There's definitely a lot more that can be done. So the early results that we have learned from these, as well as sharing with clinics and learning a lot about what they can see in their practices from the reports. We're seeing a lot of variation across the state. And we took a look at clinics by region, and the data that we're seeing is that there's a lot of variation between regions in the state, and there's a lot of variation also between clinics within any particular region. So these are things that we really want to look into over the next few years. And based on a quality index that Q-Corp developed, there appears to be little correlation between quality and cost, and that chart up here shows that variation. The fact that there isn't a line of clinics and that it's kind of spread out all over the place indicates that there's very little correlation between those two metrics. And this is a conclusion that other regions across the U.S. and other groups around the world have found in the cost versus quality and just in how costs stack up. So this work is just the beginning for Q-Core. There are a lot of things we're going to be able to do with the cost data that we have. We'll be reporting, we'll be distributing reports to clinics again this fall and intend to do so into the future. And as we get more data on cost and these measures, we'll be able to look at trends and how the measures change over time. As well as we plan to learn how to provide assistance to clinics in how to use these reports to reduce costs. I mentioned that the measures are for a commercially insured population. We're looking at how a similar methodology could be developed for the Medicare population and the Medicaid population. On the cost side, these populations are very different, and we probably won't be able to combine their cost information, or it won't be easy to do, but we do want to be able to look at those other populations to get a broader picture of costs and cost variation. As part of the national network, the work that we're doing with on the national side, we're working with other regions, and we are mentoring one region who is beginning this work, the Utah Collaborative, on implementing these measures. And there's more information about our cost work on the website. I just want to give a plug to that right now under our work, Total Cost of Care. There are links to the Health Partners methodology, as well as the risk adjustment methodology that we're using, which is the John Hopkins ACGs, and then more information about what we've learned. So now I'd like to turn things over to Cindy, who will go into the other measures that are in the report.
Hi, everyone. This is Cindy McElhaney. Thank you, Doug, for that kind introduction. So before I start talking about the next slide, I thought I would give a little bit of background on just the planning process for the statewide report and how we decide which areas we're going to focus on. And basically, we start usually in the early spring, and we start identifying what questions we think that people in the community may have about our performance on quality and resource use in the community. And we use those questions to structure our analysis and come up with an outline of the report and decide which things we're going to take a deeper dive into. So this first slide here was response to basically one question that had bubbled up through our various community engagements, and that basically is that the state of Oregon has invested a lot of resources into the PCPCH recognition program. Clinics are investing a lot of time and energy into becoming PCPCH recognized and making sure that they meet all the criteria for doing that. And the question is, has all of that effort been worth it? Are we actually delivering better quality of care through the PCPCH model? So we decided to take a look at that. We selected 11 of the measures that we report to basically do a comparison between the PCPCH recognized and the non-PCPCH recognized clinics. These 11 measures, internally we refer to them as the measures of high interest. It wasn't a real scientific process for selecting these measures. For the most part, they're CCO measures, and they're measures that various stakeholders thought were worth looking at when we were first vetting what we wanted to do with the statewide report. The little infographic, which I actually love on this chart, with the one with the little dollar sign, there are 3 measures in this comparison that are actually CCO incentive measures. That's the SBIRT measure, the adolescent wealth care visit measure, and the developmental screening measure. The rest of the measures, with the exception of 2 of the diabetes measures, are actually CCO performance measures. So the state is being held accountable for those too. So they're really important measures to focus on. What we found is that for the 11 measures, 9 of the measures, when we compared clinics that were PCPCH recognized versus non-recognized clinics, performed better on the measure result. We did some testing of statistical significance, which I won't bore you with the details with. Of those 9 measures, 7 were statistically significantly better than the other ones, which means it's a true difference. It's not a difference that's just due to random variation on there. So the chart has asterisks by the measures that are statistically different. There were a couple measures where just on the raw numbers, it looks like the non-PCPCH measures did a little bit better. Those were with the cervical cancer screening measure and the well child visit measure. But when we did the test for statistical difference, there is really no true difference between those measures on those. So the other question that we were asked related to PCPCHs, which is not reflected on this slide, was there was a sense among a few people that, at least for the initial clinics that received the designation, that these clinics may have been high-performing clinics initially. And so they wanted to basically test to see if this was just kind of a selection bias, that if maybe the PCPCH clinics were doing better just because the reason they got the designation is because they were already higher performing. It's a real hard analysis to do in a real scientifically rigorous way. Part of the reason for that is our database has changed over time. We've included other data suppliers, including Medicaid, including Medicare fee-for-service. And so when we try to do an analysis where you look into the past, there's a little bit of noise in there that's really hard to control for. The other thing is the measures have changed over time, particularly the breast cancer screening and the cervical cancer screening measures were updated to reflect new U.S. Preventive Service Task Force guidelines, makes it hard to compare. But what we did as kind of a proxy for that is we looked at our 2010 data and we compared it to our 2013 data and looked at the clinics who were high-performing clinics in 2010 who were still which was before the PCPCH program rolled out, to the clinics that were still high-performing clinics in 2013. And what we found is that 80% of the clinics were still high-performing clinics, which is an indication that assumption that some of the high-performing clinics were some of the early adopters for the PCPCH is likely true. But the other thing is that there was a significant number of clinics who were lower performing clinics in 2010 who are now PCPCH designated and are on our list of high performing clinics. So there has been improvement from the PCPCH program. Okay. All right, this next slide here is our statewide snapshot, which is on page 13 of the statewide report, if any of you have looked at it. I'm getting old and my eyes aren't as good as they used to be, and I find this chart on the right-hand side is really difficult to read. Don't worry, we've broken it down for you in the next couple of slides. A couple things that I'd like to point out here is this table right now includes 27 different measures. I went back and looked at the first statewide report that QCOR had produced in 2009, and in 2009 we only produced 11 measures. So this just kind of speaks to how much we've grown and how much more we're looking at. The other thing I would note, this list here is not a complete set of all of the measures we've produced. We produced a few other measures that are reported in other venues that didn't make it into the statewide report. So it's a long list of what we're doing, and it's frankly quite a lot of work. One of the other things I want to note on this snapshot is these are clinic averages and not population averages. And so what that means is every clinic is given a measure result, and then we average those measure results. So in a way, it's an average of the rates. The reason you do that from a statistical perspective is it allows you to compare clinics to each other and not necessarily compare populations. All right, so the next slide here, at the top of the chart highlighted in green, these are the list of measures where we are above national benchmarks on our performance for these. One thing that I wanted to note is the appropriate low back pain imaging, which is the third measure on the list. It is not only better than the national benchmark, it is better than the national 90th percentile for the measure. So we're performing very well on these. The other measure that I think we're performing really well on, even though we haven't quite beat the 90th percent yet, is the diabetes HbA1c screenings. Whenever we do any kind of an analysis, this measure pops to the top as one where we're doing really well. Next slide. These are the measures that are on the list that are highlighted in red where we are actually below the national benchmark. Some of this will not be news for people. We've been improving in chlamydia screenings over the years, but we are still well below the national benchmark, which is 48.9%, and we're at 42%. The adolescent well care visit measure, this is a CCO incentive measure. One of the reasons it was selected is because this is an area of care that's very important and where we do not perform well when compared to national benchmarks. A little bit more on that later. The other thing I wanted to note is there are 2 cholesterol screening measures on this list where we perform worse than the national benchmark. One thing that's worth knowing about these is these 2 measures are actually being retired next year. Actually, they were retired this year, so in next year's statewide report, they won't be there. And it's because for these populations, the recommendation is that people just be put on statins and no longer have these screenings monitored. And so we think that one of the reasons that we're performing so poorly on these measures is because of the change in the guidelines. That people are actually following the guidelines and the measure hasn't caught up yet. Right. Next one. Okay, so after we did the statewide snapshot in the report, we picked a few measures that we thought were worth doing a deeper dive into their performance. The first one that we took a look at was adolescent well care visits. This measure, as Kate mentioned at the very beginning of the presentation, I'm involved with the OHA helping them validate their CCO metrics. And through that channel, I know that within the CCO community, there's a lot of frustration because they haven't been able to move this measure as fast as they wanted to. One of the things that we have the ability to do, though, one of the questions we wanted to answer was, what's it look like for the commercial population for this measure? And what's really interesting is that when you compare the measure from last year to the current measure we're reporting in the statewide report, there has been quite an improvement on the commercial side. And you can see that what the state is finding for the CCOs with the Medicaid measure is true. There's a little bit of improvement, but not as much as they want to see. Oh, one other thing I should mention about our Medicaid data, the rates that we report in this report include all Medicaid product lines or plans, and so it's not only CCO plans, but the Medicaid fee-for-service, which is mostly dual eligibles, is also included in here. Developmental screenings. It's another CCO incentive measure. This measure, I think, the state has a lot of reason to congratulate itself on this because we have been making some really marked improvements in rolling this measure out. The Medicaid population, that's like a 10% increase, if my old eyes are seeing that right, year-over-year improvement. The commercial population has even been more. I think this does speak to the question of whether changes at the practice level to improve measure results for the CCO population, I think they are kind of flowing into the commercial population. None of this is a real scientifically rigorous analysis. I know other people in the state are looking at that exact question, but it's an early indicator that that is going on. The other thing that we wanted to point out is even though we've been doing really well on this measure, when we look at the map that's on the right-hand side that shows the measure result by geography, there is a lot of geographic variation with this measure. So, you know, Central Oregon is getting almost half of their kids that are supposed to get these developmental screenings are in there getting the screenings. And then you compare that to the North Coast, and it's a 20% rate, which is well below the state average. And so, you know, what we're hoping is this is an opportunity for people to at least identify where we're struggling and maybe adopt some best practices to improve these results. Right? Here's a couple more charts. Geographic variation has been a theme in our statewide report over the years, and we took a look at a couple other measures. The chlamydia screening measure, again, a lot of geographic variation. The Portland metro area has a 47.7%, which is actually better than the national benchmark. But as a state as a whole, some of the other regions are dragging us down. Again, the North Coast has a very low rate. The other map on the right-hand side, this is the diabetes HbA1c measure. And as I stated before, this is a measure where we perform really well. We're above the national benchmark. We keep improving. But even with a measure where we're improving a lot, when you drill down into the detail a little, you can see that there's variation and there's probably still some opportunities for us out there to do even better. And that was it for my section of the presentation.
All right, so thanks everybody. I do have a couple of questions, but for anyone who was waiting, go ahead and send your questions in through the GoToWebinar control panel. Let's start. One of our colleagues in Maine wants to know in the state snapshot, Cindy, where we get the national benchmarks. And perhaps that's a detailed answer.
It is a bit of a detailed answer. The national benchmarks, for the most part, are HEDIS benchmarks. But anybody who's familiar with HEDIS reporting knows that typically the benchmarks are displayed for different populations. They have separate ones. There's a commercial benchmark. There's a Medicaid benchmark. There's a Medicare Advantage benchmark. Because we combine our data across all those payer types and we produce a combined measurement result, we came up with a way to basically create a weighted benchmark from the HEDIS HEDIS measures. And so basically it's a simple weight by the population included in the measure for each benchmark. So for example, it's easier to think about with the pediatric measures. Say they're 50% commercial and 50% Medicaid. The commercial benchmark is given a 50% weight. The Medicaid benchmark is giving a 50% weight, and they're combined. Does that answer your question?
Yeah, so Laura, feel free to write back in if you want some more detail, or I'm sure that Cindy would love to
I can talk
all the live long day. There's a long story, I'm sure. So another question that came in is, do you have information about federally qualified health centers or FQHCs in particular and how they've performed, or you know, any really kind of specific group, or is data just aggregated together for the state as a whole? So I think there's probably a few different ways to answer that.
There's a few different ways to answer this. So most of the information in the statewide report is roll-ups of the information that we actually provide at the clinic level through our provider portal. And we do have FQHCs included in that data. To make a long story even longer, we have a provider directory that we've built that basically has all of the PCPs. We're trying to get all the PCPs in the state and their clinic affiliations. And so basically, if your FQHC is in that provider directory, we actually get a report out. And when you go out and look at our public report, you can identify FQHCs because we actually put a little asterisk by them with a footnote because their data does look a little bit different than for some of the other clinics, and we just want to account for that.
And this is Miley. I would just add to Cindy's comments. So the way that you can find those publicly reported clinics is also on our website.
Yeah.
At another link that shows the different clinic level results translated for the consumer audience.
Right.
And I've been throughout when we've mentioned things on our website, sending through the chat feature. I'm sure you're all dedicatedly paying attention to the slides, but should you not be, or you want a little break, I've provided links to all the different things we've talked about. So I'll also include one out to the public reports that are at the clinic level, so you can take a look at that. Unless there was anything else on that one, there's another question that came in, and I'm going to read it directly to make sure I get it right, which is, did you say you're including all payer details in the section of the report that shows all of the quality measures? If so, what's the reason behind including all payers?
Okay. So yes, we are including all payers. The original rationale way back when Q-Corp first started doing these reporting was that it was an underlying philosophy that it shouldn't matter what payer was paying for the service, that all Oregonians deserved high-quality care. And so the focus was supposed to be on just how the clinic was performing with all of their patients. For some things, like Doug mentioned earlier, when we start getting into cost of care measures, it doesn't really work because the costs look so different. And there may be times in the future where we decide that for certain measures it's probably more appropriate to separate it by payer type. But for right now, we include all payers in the same measure.
And this is Malia, just to add, I'm not sure if your question was more about all payer, all claims database. It was just including all payers, but just maybe to underscore the larger point, that the way that we get the data is through a voluntary process of the health plans, the state, and CMS providing that data for us. And to Cindy's point, sometimes it's appropriate to use a subset of that. For example, in the total cost of care measures, it's a subset of those because we have permission from a subset of data suppliers to use the cost information in the way. So that would be the one addition I would add to that. And I don't know if that answers that person's question, Kate.
If it doesn't, feel free, or if anyone else has any other questions, feel free to chat them in. While we're waiting for everyone to make sure their brains are free of all the questions that they have, just wanted to note some of the resources that are available. If you try clicking these links, I'm sorry to disappoint you, they won't work. But we're going to post a PDF of these slides to the website later today, and in that PDF, you will be able to access all these links. And I've actually sent a lot of them out over the course of the presentation in the chat box. We have our work linked to more information about cost of care, the Oregon Maternal Data Center, and the Patient-Centered Primary Care Institute, which is actually a whole separate website that contains many treasures, including the 3 webinars that are linked on the right-hand side. So if you're working in an organization looking to improve adolescent well-care visits or developmental screening, we have recorded webinars from content experts here in Oregon about those very topics, and so feel free to access those for your own training use and purposes. And then in the bottom left-hand corner, you'll see links right to the provider portal and our public reporting. So again, like Mylea and Cindy talked about, we report by clinic to the public on our website, and there's also a provider portal where providers can log in to see their information and at the patient detail level. The one other thing is that, Cindy alluded to the growth and the measures that QCOR reports on, has reported on over the years, and that's a reflection of the proliferation of measures that exist in the world. And if that's something that's on your mind, QCOR is going to be hosting, along with some other partners, a webinar on measure alignment. So there's a link to register in these slides, and I'll chat one out here in a minute, where you can participate in a listening session about measure alignment and what that would mean in the state of Oregon. There's certainly much more detail about that on the website, so I'll make sure that I include that link, and you can check that out and possibly participate there. It looks like while I was talking, someone asked a question about, for the 2% decrease mentioned in the slides of cost, how was the 2% reduction target developed, or was that just a number that you picked?
No, we did. We made a calculation from the average cost of commercially insured, Medicare, and Medicaid to come up with that calculation.
Great, thanks. All right, so I'm going to go ahead and send out, talking and trying to send you guys a link. I'm just not that good at multitasking. So I'm going to send a link out right now to the follow-up webinar on measure alignment. One more question. Do you know what % of the lower performing clinics that became PCPCH PCPCH recognized ended up improving their quality results?
I do not know that exact percentage. That is something we could probably go back and look at the data and get the answer to the question, but off the top of my head, I don't know what it is.
Yeah, and I know that we did do a little bit more about it in the statewide report, so I know the text of the statewide report, but it's a good question, so thanks, Betty, for surfacing that, and we might, that's something we might be able to consider for a future statewide report.
Right.
Okay, any last questioners, and if not, maybe we'll see if anyone here has any concluding thoughts.
This is Mylea. I would just say that this is an ongoing evolution, and we strive to make this report better and more meaningful each year. So in addition to your questions, we would love your feedback and any suggestions or ideas that you might have. We would love to have your suggestions and any feedback about the usefulness of this information and how we can improve it.
All right, thank you to everybody for joining us today, and we look forward to hearing your thoughts and suggestions, as Mylea said.